record on this computer. Good. I never record in the cloud. All right. Okay, let's start. First of all, this is MED210, Wednesday evening, week 6, June 30th. And I had reports that people didn't get their actual midterm exams. I was sending it out on another machine, and it doesn't look like it took. So I'm gonna try to maybe tonight or definitely by tomorrow morning resend out the results. So please, if you get something, please confirm that you got it, because last Sunday I just assumed that everyone got it, and then one class started reporting in, I didn't get it, and then another class, and I assume your class too probably didn't get it either. So I'm gonna resend it out either tonight or first thing tomorrow morning, depending on my mood. Well, depending on what machine's available and such and such. So what are we doing? Let's look at the announcements first. And we are in week 6. And there is a week 5 pre-recorded lecture that I placed in here. Let me just mute. Thanks. Welcome, welcome. If you're joining the party, we are just notifying you of there is a pre-recorded lecture for week 5 already in. I had to redo it because the other one was so old and it just looked bad, and it was like semi-corrupted. So, you know, every once in a while you gotta, you know, just redo stuff. So what are we doing this week? And of course, what's due today? Task 5, discussion 5, lesson 5, and what are we doing today? We are doing the skeletal system. Now, it's kind of good that that we didn't have a lecture last week, because the order of this particular class for week 5 and 6 is a little bit backwards. We really should do the skeletal system first and then the muscular system, but it's okay. And as so we'll do this today, and then in the course of the next couple of days, watch that video, and that'll be the muscular system. So the skeletal system. Now, the main thing we know about the skeletal system is that it's utilized for support. And we're in chapter 6 of our open stacks. And it is also related to movement and stability, just like the muscular system. And even though we do discuss these things in a vacuum, they're all related. Like, for example, I cut your tendon, you can't walk. You won't be able to have any movement. You won't be able to stand up straight. So that's movement and stability. But if I drill a hole in your ankle, in your bone, right, and I bypass that, bypass any muscles or tendons, you're still going to have a movement and stability problem. And also, anybody on this call ever broke anything like a finger or any bones?
I broke my wrist.
Yeah, how were you, like, even when you broke your wrist, how did you walk? Did you walk up straight and with confidence, and were you able to run down the stairs?
No, and
No.
I was actually scared.
Yeah, and it hurt like the dickens, didn't it? If you ever meet me in person, look at my 3rd digit left upper extremity, my middle finger left, and it's all messed up because a truck fell on it in my youth. And I can tell you, I was not standing up straight. There goes my stability. I wasn't moving very fast, and it's only a finger, you'd think. But again, all of our systems don't exist in a vacuum. They all affect each other. But you guys are ladies, you are female. So broken bone to a male patient is the level of pain and experience is very, very difficult. Because remember what we talked about before, the female patient has a much, much higher threshold of pain. Okay, so, but of course we pay attention to all of our patients. But if a female patient says it really hurts really bad, I would tend to believe them a lot quicker than I would a male patient. If I told you something hurt really, really bad, it's probably a paper cut. If my wife told you something hurt, really, really bad, it's probably on the level of childbirth. So knowing and understanding all of that, that movement and stability are the main physiology of the skeletal system. And when we look at our bones, we kind of think of them as, like a piece of wood or a piece of steel. It's you don't think of it as hollow, and you don't think of it as a living, breathing thing that grows, and that also can be diseased, that also can have cancer. And we're going to look at that right now, if I can find my OpenStax. And it's chapter 6, I believe. Okay. Okay. So the bone, and it's not like a fossil or a rock. It's a living, breathing thing, and it has several functions actually. And movement and stability, yes, and protection is one of them. And we're also going to talk about the different classifications of bones. And we're not really going to talk about bone formation and development too much, but we are going to talk about something called remodeling. It's the reason why, maybe you guys have heard this, that, oh, your bones are stronger and lighter than steel, which is true. And because of this thing called remodeling that bones do, especially little kids. I always talk about, when I was in EMS, barely 2-3 months. And one of the calls was they found a baby, an infant, maybe 1.5 years old, who fell 4 stories. And the only thing that little baby girl had was a partial fracture of her femur and her collarbone. That's it. No brain damage, no nothing. I suspect that she hit a couple of fire escapes on the way down. Well, this is how it was going down. Her and the babysitter and her sister were playing hide and seek. And you guys, if you guys are familiar with an urban environment, many of the apartments in New York City have bars on it. But the bars, most toddlers and regular sized adults can't get through, but a baby can. So this baby was being clever, didn't want to get caught for whatever reason, and then slipped into between the bars. Unfortunately for her, it was raining, and she slipped and she fell about 3-4 stories. Now, why am I saying that? Because when you're younger, the remodeling, or the ability for the bone to fix itself or remodel itself, is far greater than an adult. And especially when the adult already, or the adolescent, stops growing. And we're going to also show that in a little bit of, I'm going to show you a little bit of fractures and pathology. So that solves these two things, like how does the bone form, and how does it repair it and fix itself. We're going to touch on exercise, nutrition, and exercise and nutrition a little bit, but not too much. But we're definitely going to be talking about calcium and its role in why is all of that so important. Let me fix this one thing. Okay. Got a couple more people in the room. 1, 2, 3, 4, 5, 6. 6 plus me, that's 7. We're good. Okay, next. So we already know supports the body, protects, right? But what we don't know is that it's hollow and it has things in it. And one of the things that it has in it, and we're going to show in a minute, is bone marrow. Those of us who love our oxtail soup and sopa de res, for all our Latin food lovers out there, there's marrow, which is salty goodness and tasty fatty goodness. Because what's inside bones? We have yellow marrow, which has a lot of fat and minerals, of course. The bones have minerals. And the red marrow, which is blood. And that's actually, the red marrow is where your red blood cells and your white blood cells get produced. And it gets produced in response to hormones. If you recall your renal system, if it's missing some blood, right? Let's say you're a pint short, it sends hematopoietin, right? Say that 8 times fast. That's a hormone that tells your bone, hey, I need some more blood. And that's in the blood marrow. So you could see here, when you break your bone, there's a whole bunch of things that you can't do. You're going to start leaking out blood. You're going to start leaking out fat, which is not a good thing because the fat can cause an embolus and then cause a blockage, which is never good. You won't be able to protect your internal organs. You won't be able to move very well, and you won't be able to stand up or support your body very straight. So all of that bone, all of that in the skeletal system goes awry in any pathology like cancer or fractures or things of that matter. But 9 times out of 10, it's usually we're talking about some sort of trauma or some sort of fracture. Okay. Look at this guy. He's only doing a couple plates. And he's wearing gloves on top of that. Ugh. I love weirdo gym people. Okay. And you can see here, of course, our brain. Your cranium, also known as your calvarium, also protects vital structures. Oh, this thing here, this is called a goniometer. You see how like it can like measure angles and stuff like that. This part of the brace is called a goniometer, where we measure the angle of how far my patient can bend stuff. Just as a little side note. So of course we have red marrow and a little bit of the yellow marrow, and this is outer surface of bone, and you could see inside the femur, which is the longest, heaviest, strongest bone in your body, and that's in your thigh, right? So if you break your femur, the last patient I had who fractured his femur, he was one of those bicycle messenger guys in New York City. He got hit by a UPS truck, and that's the level of trauma or the level of force that's required to break your bone and to break something like your femur if you're a healthy person. Not like the movies where, you know, in the movies you see Steven Seagal like snap people's arms and legs all day, every day. That doesn't happen in real life. In real life, your bones are quite strong, and they do a lot of things. And of course, red marrow, think hematopoiesis, right? And if you're wondering how that's spelled, hematopoiesis, or state of production of hemat, blood. That's red marrow, and yellow marrow is, of course, there's a lot of things going on, a lot of remodeling, a lot of growing. So it's fat storage, because remember, yellow means fat, and it's not really yellow. It's kind of like a milky yellow. So if did anyone ever see like a bone really like broken like all the way through and it's like sticking out, like not in the movies but in real life? Anyone ever see that? No. You guys don't.
I've seen it. It is gross.
Yeah,
And I was
gross, right?
actually surprised that I could see blood popping through the
But do you
bone
see
marrow.
did you ever see any like it's like a milky, clearish white stuff? Like
Yes.
pus? That's not pus. That's fat. Right? Because you didn't have time. So now you know the two things that are going to leak out of your bones if you have a fracture. Which sounds like a good what? It sounds like a good both A and B question. Yes. So that's the two main things that we're worried about when in the fracture. We're worried about that fat embolus, and we're also worried about loss of blood as well. The pain is the last thing we're thinking about. Also thinking about if it's an open fracture, we're also thinking about infection. That's why if you break your bone and you go to the ER and you're stable, you just bought yourself 8-9 hours of waiting time, because in the ER we have something called triage. I have to get to the people who are in danger the most. Okay. But yeah, but if there's a presence of a potential fat embolus, that is a cause of concern, and we'll push you up the list if you're in my ER or anybody's ER. I always say stuff, my ER, as if I own it. So let's look at the different classifications. This is your manubrium sterni, or your sternum. This is the body, right? It looks like a necktie to me. And at the very end, that's your xiphoid process. That's the point where, you measure, you measure for CPR, if you guys remember that, some of you had CPR, and it's a flat bone. And if you look at it sideways, it's flat. Now, another tricky question that might be on future anatomy exams is your skull is also a flat bone, because but it's flat, but it's like curved, and it's relatively like, thin and flat, just like your sternum and just like your skull. So those are some examples. This is your femur, the largest, longest, heaviest bone in your body, and it's supported by a lot of tissue here. And you could see this is a long bone, and we're going to talk about the parts of that as well. Your patella looks like a seed, hence the term sesamoid. You also have like these short bones or cuboidal bones here in both your ankles, which is called your tarsals, and also in your wrist, which are called your carpals. Then you got the weirdos. You got irregular bone, stuff that doesn't fit in any classification, and your vertebrae fits into that mold. Another one is your pelvis, which is your, you have your ischium and your ilium and your pubis. Those don't follow any of these other categories. So I could ask you, what's a flat bone? You can say sternum. What's a regular bone? Any part of your backbone or your spine or your vertebrae. And you can see here, lovely. I can tell you right now, we're going to also show you the different types of vertebrae. And if we have time during dissection, you should be able to look at a loose vertebra and tell me what level it is. And we're going to show you how you do that as well. So long bones, short bones, flat bones, irregular bones, and sesamoid bones. Okay, and here's some examples. And of course, the function. All right, flat. Well, why am I starting in the middle? Long, of course, that's for what? We're going to talk about the appendicular skeleton. So it's going to be talking about leverage, and that's how you lift things. Short bones, the carpals and tarsals, which are your ankles and your wrists. The flat bones, either points of attachment when your sternum and your ribs, right? And your scapulae, which is your shoulder blades. And of course here, lovely cranial bones as well. Irregular, those are weirdos. That's vertebrae, some of your facial bones. And sesamoid, of course, is your patella. And your patella, okay, I'll take this, but it's a little bit more complex when you get into further training on the function of your kneecap. But yes, it's a protective function. So let's look at a typical long bone, and the classic example is a femur. Doesn't this look like a beautiful picture that I could put on an exam where I can just erase all of these and just go A, B, C, D, E, F, G? I could. So you could see bone is two types. The bone that we saw earlier with the red and yellow marrow is called spongy bone. Okay. Now, if you see here on the sides, how everything's like in like a rolled up newspaper, and it's very, very tight, and that's compact bone. So that's where we get how the bone is so light, because it's hollow and it has things in it. It's not solid. You have articular cartilage on the ends. The ends are called epiphysis, and if it's away from midline, it's your distal epiphysis. If it's closer towards your midline, it's your proximal epiphysis, right? And it has articular cartilage on the end now cartilage is just like bone, but it's softer because it has less mineral deposits on it. And the function of cartilage is it's utilized as a shock absorber and to decrease friction upon movement. And when you get older, this stuff starts to wear away. And then you get arthritis and all these other things. And arthritis, inflammation or infection of the joint space. And a joint space is anything in between two bones. So your pelvis would be here, so that would be the joint space. Okay. If you see this little line here, and that demarcates the difference between your proximal and distal epiphysis and the rest of the shaft, also known as your diaphysis, that is where you actually grow, right here. Your epiphyseal line. When you're a kid and you're still growing, it's called the epiphyseal plate, and it's a crucial place of growth. It's also the place that we can also tell, especially if we find your bleached bones in the woods, you know, because you met an untimely fate with some psycho, right? This is how we can tell how old you are. Red marrow, okay. Now, you have this covering on the outside. It's called your periosteum. It's very, very tough, and it's the covering of all bones. And you also have yet another covering on the inside called your endosteum. So use your medical terminology powers. Peri means on the outside. Endo means the inside. Oste means bone. Structure of. Structure of the outside of the bone, periosteum. Structure of the inside of your bone, endosteum. And of course, there's some yellow marrow, red marrow, all throughout here. And all throughout here, there are a whole bunch of holes, and we're going to show them all to you momentarily. Arteries, veins, and nerves run through it. And that's why you break your bone, it's going to touch a nerve, and it's going to hurt like the dickens, because there's nerves in there, and you could feel and sense things. It's also, maybe some of you maybe had some damage or have some arthritis. You know, when the weather gets a little bit cold, you feel it in your bones. You should, because heat and cold can expand and contract bone and other tissue, and you can feel it in here. That's why now I know exactly how my uncles and my father, when we used to go hunting, knew when it was going to be snowing or whatever, when it was bad weather. I just thought they were just, I don't know, just jungle gurus or something like that. But I now feel the same way. When the barometer drops a little bit, I feel it in my joints, and it's not a good feeling. And it's because of you got nerves in here, and it senses things. Okay, so lovely picture. Hint, hint, lovely thing to put A, B, C, D, E, F, G on. Okay, let's talk about these things. Osteocyte, osteoblast, and osteoclast. You won't need to know what they look like. So let's draw a little diagram. Where's my Microsoft? So let's draw a little cycle here. I have an osteoblast. Osteocyte. And let's move a little bit further down here. And I have an osteoclast. So an osteoblast, if you look at the suffix blast, it means immature. It doesn't do anything yet, right? Don't know nothing yet. So osteoblast will then mature to an osteocyte. Osteocyte is the mature bone cell. Now, if there's damage, or, you know, when the bone cell gets a little bit older, then what happens? The osteoclast will then break down the osteocyte, recycle some of its parts to make more osteoblasts. This cycle here is called remodeling. It is the reason why if you chop off the distal portion of a 2-year-old, distal portion of their finger, it has a propensity to go back. You can't do that to a 4-year-old or a 5-year-old or heck me, right? because this process, it gets, doesn't, at the height of your age of when you're growing, when you're in your teens, early 20s, this cycle goes in the full blast. Okay. And it's very good. It makes new immature cells very quickly, matures to mature cells, and breaks down all the mature cells that are old or damaged. And this is called remodeling. And when you're a kid, this goes round and round and round, no problem. When I was a kid, I get knocked down by a wave, hit by a car, right? I got shot with an arrow once when I was a teenager. You name it. It probably happened to me. But it was easy because why? You're young. And this system is what? Efficient. But what happens when you get older? Less blast, less immature, immature remodeling, and more what? Breakdown. And the more breakdown you have, the more chances you have for arthritis. So blast, osteoblast, immature bone cell. Osteocyte, mature bone cell. Osteoclast, right, are breakdown bone cells. And all of this, the interplay of all three of these types of cells and the cycling through these types of cells is called remodeling. It is what gives bone strength. Here's another example of that flat bone, little sandwich here in your cranium, right? You have that spongy bone and then lined with compact bone. By the way, they make fighter planes like this now. They don't make them out of metal anymore. They make them out of carbon fiber. By the way, guess what human beings are made out of? Carbon. Yeah. So whoever built us pretty perfect. And now we as advanced thinking organisms, now we're doing and making things that are lighter, faster, and stronger. And carbon fiber, that's why if you see, all those silly, too fast, too furious kids on the highway, spending, $800, $900 on carbon fiber parts for the car to make it lighter. Ugh, so silly. My nephew's one of those people. So annoying. But is what it is. One of these days, you are going to need to know all the parts of the bone. But right now, we're only going to go over the bones. So like the basic names of the bones. But every bone has all these little grooves and ditches and things that stick out like projections and protuberances and processes, tuberosities, crests, ridges. The holes are called foramina, and you have fossa, which are depressions. There's a whole bunch of things. By the way, all of them have locations and meanings and physiology connected to it. So if you would like to be in gross anatomy in medical school, you will be going over all of these. So what do I mean by that? So you see this tubercle, it has a name. This has a name. This groove here, this. And by the way, every hole has something that goes through it. So you got to know which goes. So this is foramina for your sacral. This is your sacrum. So this is foramina or holes. S2 through S4 nerve plexus runs through there. And also your cauda equina runs through by there as well. So all of that, this is a crest, this is a fossa, and they all have names. But for right now, just know that the bone is way more complex than just calling it the femur. But for right now, we need to know this is the femur. We know this is an epiphysis. This is your proximal. This is your distal. This is your diaphysis or shaft, right? And the transition is your metaphysis, which is here and here, okay? But you can see here, there's actual names. It's called the head of the femur, and then your fovea capitis, and then also your lateral subtubercles and all that. Oh, it's horrible. I don't even want to think about that. And this is your humerus, which is your funny bone, which is your upper arm, also known as your brachium. There's also sinuses, holes. All of these also have names. But again, all we need to know for our purposes right now is that your skull, just like the rest of your bones, is also hollow and there's things in it. So when you get sinusitis, that's how you know that's how you feel your head's like a bowling ball. And then you start talking funny because you get all gummed up here with pus and heaven knows what. Osteocyte, osteoblast, osteoclast. Oh, by the way, osteoclast, or when the breakdown of bone, is also called bone resorption. resorption. That's that. Or bone breakdown. Well, here's a nice little review of the little two-dimensional chart I just drew. Now, let's look at this. Another lovely diagram, which has a lot of potential for A, B, C, D, E, F, G. Let's look. So this is a cross-section of typical long bone. And you could see how you have your periosteum. That makes sense. You could see how it is all inundated with all these canals and these pathways that have the red is an artery, blue is a vein, and the yellow is a nerve. And they're all in here. And you could see it's formed up of these circles. Each one of these circles, also known as a functional unit of bone, is called an osteon. Okay? So what does the osteon have in it? It has all the bone osteocytes in these layers called lamellae. Okay? And I mentioned a newspaper earlier. You guys know, if I tried to hit you with a couple of pages of newspaper opened up, loose, right? You look at me like, what's wrong with you? It won't affect you. But what happens if I rolled up that newspaper nice and tight, and then I bonk you on the head with it? You'd feel it, you'd know it, and then you could see how something as light and as innocuous as a couple of pages of newspaper, if properly organized and in concentric circles here, such as your osteon, in these layers called lamellae, it gives your bone a ton of strength. And it's just like, you can snap a twig, but if you put a whole bunch of twigs together and you wrap them all up in this periosteum, and then you protect it on the inside with the endosteum, this thing becomes quite strong and very, very light. And it's a living, breathing thing because you could see it's inundated with arteries, veins, and nerves. Okay. And this occurs in compact bone. What else did I? Oh, then the spongy bone, also known as the medullary cavity, that has all the marrow, yellow and red marrow in it. But you could see how the inside, nice and soft and mushy, the outside or nearing the outside, nice and strong and tough. Okay. Then again, we're not going through pathologies. You have a wonderful class with Dr. Bettini on that in your future, once you guys make it to nursing. Hello, next. Got stuff to do. Oh, here's how bone is formed, but again, like I said, I'm not going to touch on that. You'll see that maybe if you ever take a developmental class. I don't find it clinically relevant for you guys at this time. And again, that remodeling that we talked about. Let's get to some pictures. Okay, let's look at some fractures. Closed is preferred over open because it's in the inside. Because once it's open, then all of those arteries, veins, and nerves and the inside is now exposed to the outside. Transverse fracture is a fracture that goes straight across. Spiral is a twisting kind of fracture here. If any of you ever watch football, that's why a lot of football players hate, the artificial turf, because their foot stays still. They twist around, maybe when they're doing a button hook maneuver. Don't you guys miss NFL? I do. Comminuted fracture, you can see it's all shattered. Gunshot wounds, GSW, are comminuted. These are nasty and they're hard to they're hard to heal. And the thing about a bullet is it's not really the bullet has to hit that bone. The very force of the bullet traveling in you is enough to shatter the bone. That's how powerful that little piece of metal is in there. And this is also the other horrible thing about bullets. And it's the irony of it all. I love shooting, but I hate what it does to human beings. When the bullet hits here and hits something hard, it tumbles. And that tumbling is called cavitation, and it ruins more tissue than a normal bullet just coming through. And you've heard of dum-dum bullets or soft tips or Teflon. When they hit something hard like bone, they mushroom out and they make like a million pieces, which cause even more damage. Don't you find it amazing how human beings, how we can use our brains to do gosh awful things? Don't you love the fact that we're in healthcare, that we're here to repair people and not destroy people? Impacted typically with people who, jump from a height. Maybe they were doing parkour or something stupid like that. But I've seen a lot of these fractures and compression fractures of the spine. Hold up. Yeah, you guys go ahead because I'm not sure. All right. So I've seen a lot of this because people who I'm depressed and I want to jump off a building. When I was in EMS, the majority of the people who attempted suicide lived, and some of them didn't came back worse for wear. So something to think about and something to get to your patient who has suicidal ideation. The majority of them, they'll live and they'll be far worse off than they were before. How many of my patients didn't know anything about anatomy and physiology? They shot themselves in the head and they lived with significant brain damage or blindness. I had a patient, he shot himself in the head, but kind of missed his brain and shot his eyeball and his nose off. And he lived. Now he's get to be blind and can't smell stuff. I'd rather just be depressed. Green stick fracture is a partial fracture. This happens with children less than 5 years of age because children don't have a lot of minerals in their bones, like calcium and magnesium sulfate and things of that matter. So when they break things, they only break it partial way, kind of like if you've ever seen like a young sapling tree. When you break it, it breaks on one side and it bends on the other. That's what a green stick fracture is. And oblique, it's what? Diagonal, right? Versus the transverse, which is straight across. And like I said, in order for any of these things to happen, it had to be significant amounts of trauma. And if it's only a little bit amount of trauma that caused you to break your bones, then that's a pathological fracture. There is a disease state going on in your bone, and something like cancer or leukemia can do that for you. Okay, look, lovely outline. Bone repair, and you could see it requires a lot of vasculature, right? And remember, it's not like a kung fu movie where in kung fu movies, like they break their bones and then when they come back, they become ultra strong. No, when you break your bone, this area now is not as strong as it was prior to breaking things. So you should protect your previous injuries. Calcium and vitamin D. We already know that milk does the body good. Calcium phosphate, calcium carbonates, right? Calcium must be derived from the diet. And vitamin D has also a lot to do with calcium absorption. And the best way to get vitamin D is through sunlight. I think I shared with you guys already. My kids a couple of months ago got diagnosed with, because I thought they were just a little bit anemic, but they're always inside the house and they're your typical coronial kids who don't go outside anymore. I even bought them bicycles and skateboards, and they still just hang out inside. Now I just force them to go outside because they need the vitamin D. And the way the vitamin D, it gets absorbed via the sunlight, okay? And then, gets processed by your liver and your kidneys, and then helps you in calcium absorption. Vitamin K, also bone mineralization. Vitamin K has a big role in blood clotting as well. So your diet, right? Vitamins A, D, E, and K are fat soluble, and they are directly derived from your diet. Okay. Magnesium, fluoride, omega-3 fatty acids, which are they're the good fatty acids that are in fish and fish oil, which, by the way, just consuming fish oils won't do it for you. There was a study done 50, 20 years ago that they made a whole bunch of people take those, fish oil pills. It didn't significantly reduce inflammation, didn't significantly increase osteoblast function. But people who eat fish, and fish is much better, right? If you can try to poach it versus frying it. That's why Japanese people live forever, right? They have the most people who are like 100 years and over, something like that in the world. Something, I forgot. It's one of those things that I always remember. I always think old age, omega-3 fatty acids, and fish, and I always think of the Japanese culture. And last time I was there, oh, delicious, absolutely delicious. And I'm a meatitarian, so it's a rarity for me to eat fish. And last time I was in Japan, I just had a blast with fish everything. Now, hormones. We already have heard of growth hormone, which is secreted from, of course, our pituitary gland. And growth hormone only works when you're in REM stage for sleep. So the stuff that your parents and your caregiver or whoever raised you told you, my mom used to say, hey, you better take a nap, you better get some sleep, or you're going to end up like a midget. And I make fun of her now because I go, Mom, I'm 5 foot nothing now. I slept all the time. But you got to think, just imagine, I wouldn't have grown to go through my maximum potential of a whole 5 foot nothing if I didn't have growth hormone to increase my calcium retention. Okay. So thyroxine, remember we talked about T3, T4, and TSH as part of your metabolism. Well, it's also part of one of the hormones that deals with your growth. Okay. So think growth hormone, think your thyroid hormones, right? And of course, sex hormones, estrogen and testosterone. All of this comes into play and influences growth. Now, osteoporosis. Remember we talked about osteoblast, osteoclast? Well, guess what happens? There's a lot of osteoclast activity going on in female patients. Now, can anyone tell me why it would be advantageous for a woman to start leaking out calcium? Why would that be a normal thing? Especially from the ages of 20 to 40, around here. Why would that be an advantage for our female anatomy to leak out calcium? What's going on around this time, right?
Is it because she can have kids?
She's got kids. Correctamundo. Thank you. Because they have breast tissue that makes milk that requires what? Calcium. So it's one of those things that's a good thing and a bad thing at the same time. So after age 50 and all over, after childbearing years, and remember, I think this is the class I always told you guys that what happens after pregnancy, things don't go back to normal. Things that kind of stay, what changed in pregnancy mode will continue on for the rest of your life. And that's why after mommy delivers a baby, or even when women start getting 45 and 50 years of age, right? the gynecologist will always start asking, or any physician will always start asking, hey, do you want to take calcium supplements? Me, I think the calcium supplements just make you constipated. The best bet is to do what? Regular exercise, because remember, if you don't use it, you lose it, right? Like I told you, my wife is in her 50s, and it's not only Asian genetics that she looks like she's in her early 40s and maybe even younger. It's because she still does Zumba on a regular basis, almost every other day. She now teaches it online. Before, even when she had her kids, she taught Zumba until like, frightening. It was like 8 months into her pregnancy, 7.5. I actually was yelling at her that please don't do that. But you know what? A lot of gynecologists, a lot of obstetricians will say, yeah, work out, but of course, tone down your workouts the closer and closer you get to the date of confinement. But working out, eating right, watching your calcium intake in order to compensate for the eventual bone loss. And that's osteoporosis. Okay. Parathyroid hormone likes to, and calcitonin, they like to influence your osteoclast. They like bone resorption activity because parathyroid hormone and calcitonin are usually in response to lower calcium levels. So if you got a low calcium level, parathyroid hormone and calcitonin will now tell your bones, hey, I need some calcium, I need some minerals. So it releases that. Okay. Now, here is a lovely, could this easily be a matching? Which of the following, A, B, C, D, E, F, which of the following inhibits osteoclast activity? Which of the following stimulates osteoclast activity? Which of the following stimulates absorption? Right here, look at this, hint, hint. This is Dr. Garais test-taking rubric right here. So if you see something like this, like that's matching, it screams what? I should go home, make up questions, and practice myself on these questions, because I know at least 2 or 3 of them will come out on Dr. Garais' final. It just has to happen. Hypocalcemia, hypercalcemia, never a good thing. Too much is never a good thing. Too little is never a good thing. There has to be a balance of this little seesaw, this little teeter-totter thing, whatever they call it. And we already talked about osteoclasts and calcium reabsorption. We already talked about the thyroid glands. So take a good look at this. And you could see here, it's plus or minus, 10 milligrams per deciliter, which is a decent amount. You don't have to memorize this, but eventually you go into the wonderful world of nursing. You got to know all of those, and they're called reference laboratory ranges. Okay, so this is a lovely diagram. Next. Okay, all right, and that's chapter 6. That is the bone classifications. Now let's look at chapter 7, and that's more pictures. Let's look at the pictures. So here's one picture. Hello. Do you think I could do this? A, B, C, D, E, F, G? Surely. This is my skull, my cranial facial, right? Cranium, which is your skull cap, and your face. Face, a bunch of regular. Your clavicle, let me make this bigger. There you go. I keep on forgetting. I can't see very well. Clavicle, of course, you're also known as your collarbone, scapula, and it looks like a scalpel or a blade, also known as your shoulder blade. Here's your thoracic cage, and we're going to go over the ribs and the numbering of the ribs in a moment. You have your brachium or your upper arm. This is your humerus. You have here your radius and your ulna. Now, which one is which? The radius is on your thumb side and your ulna is on your pinky side. That's the best way to look at it. Here's your pelvic girdle or your hip bones, and we'll talk about those specifically in a moment as well. Here's your metacarpals, and here's your phalanges. Now, you also have metatarsals and phalanges on your toes. So how can you tell your toes versus your fingers? Your phalanges, upper extremity, of course, are your fingers, and your phalanges, lower extremity, are your toes. The way you label your phalanges, your thumb is number 1, pointing finger is number 2, middle finger is 3, ring finger is 4, pinky is 5. So if I break this finger right here, I broke the second digit or second distal phalange, upper extremity left. Because remember, this is my patient, and this is their left, and this is their right. Patella, femur, tibia, fibula, tib, fib. I break the bigger one, which is the tibia. Odds are the fibula is also going to fracture too. Hence the term tib, fib fracture. Well, it's not really a term. It's like a slang. Of course, your ankle bones, your tarsals, right? The dorsum of your foot, that's your metatarsals. Now, you will notice that, let's shrink it a little. You will notice that all these like beige bones, that is your axial skeletal system. And all the other green bones, that is your appendicular system, appendicular skeletal system. So an appendicular is your appendages. And this right here is known as your pelvic girdle, which is your clavicle, scapula, and your humerus. And here, of course, did I say pelvic? This is your shoulder girdle, also known as your pectoral girdle, right here. And that's part of your appendicular skeletal system. And your pelvic girdle, and you know what a girdle does, it wraps around. So that wraps around there, and this wraps around here. So that's your pelvic bones, right? And they wrap around here, and that also includes your femur right here, especially your proximal epiphysis, also known as your acetabulum, right here. So I could ask, your skull, is it axial or appendicular? Your sternum, is it axial or appendicular? Your 12th floating rib, appendicular or axial? So this is a nice picture and a nice category skeleton question I could ask. Okay, now, you could now see there's a lot of pictures. So hint, hint, what will the majority of your final exam be, which is we're going to be talking about week 5 onward. The majority of the exam will be identification because there's tons of identification. Now, what looks good here? I don't need for you to know all the minutia because you'll eventually know that when you get into more advanced things. Just know that here on the bone, it's got these little lines in it. That used to be the soft spots when you were a kid. And then when you grew up, they started fusing together. And those fusion of those bones or those joint spaces are called sutures. And here, this one is your coronal suture, the one that sits here like a crown over your head. And you have your frontal bone, you have your parietal bones on the side, upper side, and then you have your temporal bones here. These are called your orbits, this whole entire thing. This is called your nasal cavity, and in the middle is your nasal septum, also connected to this bone here called your vomer. Your maxilla is up here, and your mandible is down here. And you could see there's foramen or holes, and there's nerves that go through those holes. Okay. Now, if we look at it from the side view, you have your parietal bone up here, frontal here. You have a little bit of your sphenoid. And this is your temporal, all this purple thing here. Your external acoustic meatus. This is, that will lead to your ear canals. Here is your styloid process right here. It's a process, means it's sticking out. And in the back part, that's your occipital bone. You can see your maxilla here, nasal bone here, and of course your mandible. Okay, which is your jaw. When you look at inside, you have fossa or fossae. Fossae, meaning plural. You have your anterior, middle, and posterior. And it makes sense because there's an anterior part of your brain. This is like a middle section, and you have a back section. And you can see here, that is the function of your calvarium, also known as your cranium, to protect your brain. And there's even a space here that's all filled with cerebrospinal fluid so that if you get hit in the noggin, it won't be a direct hit onto your brain. But if I hit you bad enough, it'll cause a whole lot of horrible things. Okay, here is the undersurface of your skull, the cranium. Now, the one thing that you really need to know is all these foramen are they're holes, and they run through all your nerves. But the one thing I want you to know about this bottom part is this is the foramen magnum. This is the hole that's going to connect the spinal cord and your vertebral column to the rest of your body here. Okay. And here's a rear view of your occipital. And you see here the lambdoid suture. You have your sagittal sutures down the middle. And of course, your two pair of parietal bones that are on the top of your head. Okay. Nah, I'm not going to ask you that. Now I'm getting. Oh, no, I'm not going to ask you that either. Let's look at some other stuff. Teeth and jaw. Just know it's mandible. That's it. Come on, we already talked about sinuses, the spaces in your bones. Oh, this floating independent hyoid bone. It doesn't stick to anything. And its function is the base for the tongue, and to attach via connective tissue to your larynx and your pharynx. And remember, your larynx is your voice box and your pharynx is your throat. And that's the function of your hyoid bone, which is floating around in here. Not really floating, but it's connected by connective tissue. Ooh, look at here. Let's look at this. Now this is your vertebrae. You can see here, if you look directly anterior-posteriorly or front to back, there's no curvature. But if you look at a patient sideways, there's a natural curvature of things. So the first 7 bones are labeled C1 through C7. Those are your cervical vertebrae. They're smaller and lighter, and they allow your head to move around. And your C1 is your atlas, and your C2 is called your axis. Atlas, C1, that allows your head to shake, yes, up and down. C2 is your axis. That allows your head to say no, left and right. So if you have a C1, C2 fracture, you won't be able to move your head up and down or left or right. Now, everyone reach in the back of their head, back of their neck, more exactly. Do you see there's like a bone sticking out? That's your C7 prominence, okay? And the vertebrae is important because especially when your patient doesn't move around a lot, or they're comatose, or they're bedridden, all the points of contact where this vertebrae is going to hit skin is going to be a potential for a decubitus ulcer, or a potential of your skin to wear away at that point. So that's your C7, or your 7th cervical vertebrae, also known as your cervical prominence. Okay, so you have your atlas, axis, and your cervical prominence, and that's your cervical, or your neck vertebrae. Now, your vertebrae in your thoracic cage, you got 12 ribs, therefore you got to have 12 thoracic vertebrae. And what's important about them are they got these little facets, and we're going to show you them in a minute. They connect to all the ribs, and also we're going to also show you the different kinds of ribs as well. The lumbar, if you notice, 1, 2, 3, 4, 5, they're thicker, right? If you look at the body of these lumbar vertebrae, they're thicker and they're stronger and they're heavier because that's going to hold up your body, right? And last but not least, you have these fused bones of your vertebrae down here, and that's called your sacrum. At one time, when you were a baby, they were all separate bones, but now they're all what? Fused. And it ends with your tailbone, known as your coccyx. And you see this sacrococcygeal curve, which gets exaggerated in the female anatomy because guess what? It's got to form a nice little ramp for baby. Okay. So those are the regions, those are the curvatures. And if you have a lateral curvature of your spine, that's called scoliosis. If you have a humpback, it's called kyphosis. And if you have what is termed swayback, it's called lordosis. And in between all of your bones is cartilage called your IV disc or intervertebral disc. And you could see how you can get a what they call slip disc, right? When you get pain and numbness, you see these nerves that are sticking out of your spinal cord? Those are your spinal nerves. You see these facets here as well, because that's how you know you're in your thoracic vertebrae. Well, if this intervertebral disc starts slipping out and starts pressing on these nerves, it'll cause pain, paralysis, and also loss of feeling in certain areas of your body, because your spinal nerve is what sends the messages up and down to your spinal cord. And sending the messages up, that is called your ascending tracts. Sending messages down, that is your descending tracts. Now, the very inside of your intervertebral disc, and this is like a disc of, what is called that? Cartilage. Excuse me there, it's getting late and I'm getting hypoglycemic. This nucleus pulposus is like this jelly-like material, and when you have a slip disc, sometimes this thing starts leaking out and pushing all of this stuff out. And if you have your spinal cord here and a spinal nerve there, it's going to start impinging and pressing on that, and then you're going to have a slip disc, and then you're going to have some pain. Maybe you've heard, maybe your grandparents like, oh, my sciatica. Well, it's because of your sciatic nerve, your S2, S3, S4, right? Your C1 atlas, you see how it goes up and down. C2 axis, that goes left and right. Your typical cervical vertebrae, they're small, they're light, so your head can be on a swivel, so you can, I don't know, pick up danger. When you look at your thoracic vertebrae, it has these things called pedicles, which connect into ribs. And of course, the lumbar, what's really important about those, you could look at that body or the corpus of the lumbar vertebrae. It's nice, thick, and heavy, and it can take a hit, and it can hold all that weight. And your sacrum, right? And that's all fused. At one time, it may have been separated, especially, as a fetus, but then eventually they'll all fuse together. Here's the example of a nucleus pulposus herniation, or a slip disc, or a herniated disc, you can see, and how it's impinging on the spinal nerve. And depending on what part of the spinal nerve it is, you could cause paralysis. That means you can't move. You could cause pain. You could cause loss of sensorium or sensation, a whole bunch of things. Next, let's talk about the ribs. Well, here's your manubrium sterni. Here's your sternum. And this is your corpus or body of your sternum. And at the very end is a little bit of like semi-cartilage, and that's called your xiphoid process. Now, here are your ribs. There are 12 of them. If you notice, the first 7, 1, 2, 3, 4, 5, 6, 7, they connect directly to the body of your sternum or the corpus of your sternum. Those are called true ribs. 8, 9, and 10 kind of connect into rib 7. Those are called false ribs. And 11 and 12, those are called floating ribs. because they only connect only in the back. And 11 and 12, your floating ribs, their main protection are your kidneys in the posterior area um, of your body or thorax. Okay, so you got to know these, which are true ribs. 1, 2, 3, 4, 5, 6, 7. And they're called true because they connect into the body of the sternum. 8, 9, 10, false ribs. They kind of connect into rib 7. 11 and 12 connect only in the back and into the vertebrae. And those are called floating ribs. And they protect your kidneys. Developmental of the skull, those are fontanelles. You have an anterior and posterior one when you're a baby, when you're an infant, and they make sure that the timing for the closure of these things, which we won't really discuss. I had enough of babies. All right. That's done with chapter 7, which is the appendicular and axial skeleton. Now let's look at not last but not least, let's look at chapter 8. And then I'll leave the joint chapter. I have a little mini video on it, so I don't want to keep you here all night. Let's look at some of the bones here, and they're not as, let me go over this. Yeah, I kind of went over this. I want to go over the hip bones. Oh, and then we kind of went over this carpals, and they're labeled 1, 2, 3, 4, 5, with 1 being your thumb, right? And the phalanges have a proximal, middle, and distal phalange on your fingers, and the same on your toes. Okay. Oh, carpal tunnel. Now, you have a whole bunch of nerves in your wrist here, and the muscle and the tendons form a tunnel. And if you use your hands a lot, and sometimes these tendons collapse, and when they collapse, they impinge and they press on nerves, whether your radial nerve or your ulnar nerve, and it causes sensorium problems. You have tingling, and also known as paresthesias in your hands, and you also won't be able to move your hands as much. I've got the beginnings of carpal, which is annoying as hell, but is what it is. Now they're going into specific fractures. I just want to go into there you go. Now, of course, we already know our sacrum. And those are your hip bones. Now, your hip bones, this is called your ischium, this round things here. And this part here is called your ilium. And you have your iliac crest, which is here, and goes, and they call this a ramus or tuberosity. And on this part here is your pubic symphysis. This part right here is cartilage. All this other stuff is bone. And sometimes it even separates in the female anatomy to accommodate the size of baby. Now, the difference between these bones, your ilium and your ischium, in male versus female, in female, it'll be more pronounced and bowl-like, because remember, we have to accommodate and carry baby. Okay, here's a little bit more. So you got your ilium and you got your ischium, and this is called your obturator foramen, and your obturator muscle goes through there. That's the only thing I really want to check out. And you can see here, male versus female pelvis, and the female pelvis, you see, is wider, and it's like it's more of a cradle for a baby versus the straight up male pelvis. Femur, well, I already went over that. It's kind of like doubling up on some of the things that they talked about. Arch of your foot, it's not very important. Limb growth, okay. So I went over everything in that I wanted to go over. So, you know what? It's only 7 o'clock and you guys paid good money. Let's go through joints instead of showing you a separate video, and it won't take too long. Now, joints are any space in between two bones. And they're important because, and arthritis is a very, very debilitating thing. It could be very, very minor, but it can easily get out of hand. I lost an entire weekend last weekend to gout or gouty arthritis. Hurts like the dickens, but again, I'm a male patient. I'm a bit of a baby when it comes to pain. But when that joint space gets damaged or the joint space has inflammation or infection or any trauma or pathology, then the bones will be affected as well. So there are classifications of joints. The first I'm tongue-tied already. The first classification is synarthrosis. Syn is the prefix that means same. So that's an immobile joint. An example are the sutures in your skull. Okay, here's your squamous suture, your lambdoid we already talked about, your coronal, which is right here. Those are your sutures. They should not move at all. If they move, you got a problem. Amphiarthrosis. They move a little bit, but they shouldn't move a lot. And a classic example is your intervertebral disc. Another classic example is your pubic symphysis that we just discussed. Another example is your costal cartilage that are on your ribs, because your rib cage has to expand when you're breathing. So those are classic examples of limited mobility, also known as amphiarthrosis. Now, what is diarthrosis? Dia means complete or thorough. So complete or thorough joint movement. And that's all the, the ball and socket, all the stuff you learned like in your other anatomy classes in high school and things like that. And here's your acetabulum and the head of the femur, and it goes right there, and that's a ball and socket joint. That joint is fully mobile. It is a multi-axial joint, move up, down, left, and right, and that is a diarthrotic joint. Okay, so those are your 3 types: synarthrosis, right? Amphiarthrosis, and what's B? And this would be an example. Oh wait, this is something else. Why am I quoting something else here? Oh, these are fibrous joints. Nice to know. It's better to know synarthrosis, amphiarthrosis, diarthrosis. They're better. Let's see. Anything else? I think I don't want to go any further in the joint space. I want to look at synovial joints. Okay. Oh, and here's like articular cartilage from one bone to another. You have articular cartilage, which reduces the friction between these two bones and the joint space. And this is called a synovial joint, which is a fully diarthrotic joint. And you have a synovial membrane, and the joint cavity will have fluid. And the fluid here is supposed to be sterile. But when that fluid gets affected with like pieces of bone, or like in my case of gouty arthritis, uric acid crystals from bad metabolism, then this space will become inflamed and will become painful and red, swollen, and then you'll have functionalethea, which means this is not going to work too well. And it doesn't take much to get what do you call that? Immobilized with arthritis. So your patient who has arthritis, make sure, take care of them, because it's painful. Let me check real quick. Attendance 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. I guess someone logged off, but I got 7 names, which is good. 7 plus 1, it's 8. Oh, no, we're good. It's just my math is bad. So that's a synovial joint. And you could see here with all this stuff. Now, do you see how it forms a pocket of fluid, also known as your bursa, hence the term bursitis, when you have an inflammation or infection of that. And you could see how whoever built this. Pretty neat, pretty perfect. Okay. Should I go over this? Well, just for you sports fans, you know when they talk about ACL, PCL, this running back had this damage and that damage. Well, they're talking about these ligaments, right? And the ligaments are connective tissue bands that connect bone to bone. And you can see here on the knee, right? You have an anterior cruciate ligament, and the word cruciate means cross, and it crosses over. And you have a particular one, and you have your MCL as well. They keep all this together. And of course, here your patella, which is a protective function here, right? And all of that together forms your knee joint, okay? Which is a very classified, very specialized, not classified, but specialized synovial joint. That's why when, running backs and stuff like in the NFL, screw this 18 ways till Monday. It's so easy to mess this up. I personally have lots of damage left versus right, all the years of skiing, snowboarding, surfing, and damaging myself and doing stupid things. That's one way of doing it. Here's more types of synovial / synarthrotic joints, and they're in of course, all the appendicular parts of your body, because your appendages, they have to move a lot more efficiently than everything else. And you don't need to know which one's plane, socket, and all that. I just need for you to know and understand what does a synovial / diarthrotic joint look like. You should know this from medical terminology, your different movements. I might ask it just for laughs. So no inversion, eversion, dorsiflexion, plantar flexion, pronation, supination, circumduction, abduction versus adduction, flexion versus extension, hyperextension in the case of the neck here as well. You can review that yourself, and you should know that from chapter 2, medical terminology. All right, with that said, I am now going to stop the recording and open the floor for questions.